Welcome to this explainer. If you've ever wondered exactly how a pregnancy begins at a microscopic level, or if you're navigating the difficult journey of IVF and just want to understand why an embryo might not attach, you are absolutely in the right place. Today we're diving straight into the intricate science of embryo implantation, and we're going to unpack a condition known as recurrent implantation failure, or RIF.
Okay, let's look at our roadmap for today. We'll be covering 1. The miracle of implantation. 2. Understanding recurrent implantation failure. 3. The seed, embryonic factors. 4. The soil, maternal factors. And finally, 5. Modern solutions for RIF. Let's jump right in.
Section 1. The miracle of implantation. The critical dialogue between embryo and uterus. We're starting our journey with the delicate biological crosstalk that has to happen perfectly to initiate a pregnancy. It's truly a microscopic miracle.
Now, you might think the uterus is always ready to accept an embryo, but actually it's not. It only opens this really brief, highly specific window of opportunity each month, usually lasting just 2 to 6 days. During this time, the inner lining, the endometrium, regenerates. Doctors are looking for a thickness of about 7 to 9 millimeters and a distinct trilaminar or 3-layered look. And all of this has to perfectly align to be ready for the embryo roughly 6 to 7 days after fertilization. And it's actually a multi-step journey. First, in the pre-implantation stage, the lining prepares itself while the early embryo divides and moves into position. We call this apposition. Then, during the true implantation stage, the embryo, which is now called a blastocyst, has to physically attach to the uterine cells and literally invade the deeper layers. It's doing this to secure a blood supply so it can keep developing. Section 2. Understanding recurrent implantation failure. Validating the biological mystery. So what happens when this highly coordinated biological dialogue just fails? When that synchronization misses the mark repeatedly, even after transferring good quality embryos into a healthy-looking uterus, we're dealing with a condition called recurrent implantation failure, or RIF.
We really have to acknowledge the heavy psychological and financial burden here. It's massive. Implantation is honestly the major obstacle in assisted reproductive technology, and an estimated 70% of all IVF pregnancy loss is due specifically to implantation failure. 70%.
So, the crucial takeaway here is that if you are going through this, you are absolutely not alone. RIF affects about 10% of couples going through IVF. And while clinics define it slightly differently, it generally means facing the heartbreak of 2 to 6 failed cycles after transferring 3 to 10 high-quality embryos. It's incredibly frustrating. But the good news is science has developed systematic ways to investigate this mystery by looking at 2 main things: the seed and the soil.
Section 3. The seed. Embryonic factors. Assessing the genetic health of the embryo. Let's look at the seed first, and the absolute most common reason these seeds fail to take root.
You know, even if an embryo looks perfectly healthy under a microscope, its internal genetic makeup is what really dictates success. We generally classify embryos into 2 categories. Euploid embryos have the exact correct number of chromosomes. They have the highest chance of normal development. Aneuploid embryos, on the other hand, contain numeric chromosomal abnormalities. And the data reveals that these chromosomal errors are actually the single most common cause of early developmental arrest, making up 50% to 60% of all first trimester miscarriages. Plus, the likelihood of these abnormalities is strongly tied to maternal age. Which brings us to a really powerful tool: pre-implantation genetic testing for aneuploidy, or PGTA. With this, embryologists can actually screen the blastocyst for normal chromosome counts before the transfer even happens. It lets clinics identify the healthiest seeds up front, essentially bypassing the most common embryonic cause of RIF. It's a total game changer for optimizing outcomes.
Section 4. The soil. Maternal factors. Preparing the optimal uterine environment. Okay, so what if the seed has been genetically tested and is perfectly fine, but it still fails to implant? Well then, we shift our focus over to the soil, the maternal intrauterine environment.
This soil can be affected by a whole bunch of complex maternal factors. We're talking physical, anatomical issues, a lining that just refuses to thicken, or thrombophilia, which are blood clotting issues. Or it could simply be a non-receptive endometrium during that specific transfer window we talked about earlier. And then there are immunological factors. For a successful implantation, you need profound maternal fetal immune tolerance. Specialized immune cells, like T cells and macrophages, literally have to activate and remodel uterine blood vessels to welcome the embryo, instead of fighting it off.
Section 5. Modern solutions for RIF.
technological interventions for the seed and soil. Let's get to the most exciting part of this explainer and see how modern assisted reproductive technologies are actively solving RIF.
If the core issue is a missed implantation window, science offers the endometrial receptivity array, or ERA. This is a highly advanced molecular diagnostic tool. Through a quick biopsy, it scrutinizes the expression patterns of 248 specific genes. Then, it uses an AI algorithm trained on data from over 200,000 women to definitively categorize the uterus as receptive or non-receptive. If it's non-receptive, the test pinpoints the exact, personalized timing required for progesterone administration. It makes sure the soil is perfectly primed the exact moment the seed is planted.
But we do need some balance here. Major reproductive societies, like the ASRM in their 2023 guidelines, actually advise against using the ERA for everyone. They suggest reserving this test, which can be invasive and costly, specifically for patients struggling with repeated failures. For routine, first-time IVF patients, combining that genetic embryo testing with a standard frozen embryo transfer is usually more than sufficient.
Now, for patients who have their timing perfectly dialed in, but still need extra support for their uterine environment, doctors can perform local intrauterine infusions. Let's break down the main options. There's PRP, which uses your own concentrated blood platelets because of their amazing regenerative properties. There's PBMC, which uses your own immune cells to promote that critical immune tolerance we discussed. GCSF modulates specific white blood cells to enhance receptivity. And finally, HCG can be infused right during the implantation window to induce the secretion of helpful cytokines.
So out of all those, what actually works best? Well, recent network meta-analyses looked at over 3,000 women with 2 or more implantation failures, and a clear hierarchy emerged. Autologous platelet-rich plasma, or PRP, stands out as the most statistically effective intrauterine intervention for achieving a clinical pregnancy and a live birth. PBMC comes in second, followed by a mechanical endometrial scratch. By combining genetically tested embryos with a deeply understood, immunologically balanced, and perfectly timed uterine environment, modern reproductive medicine is totally changing the narrative. Science is proving every day that recurrent implantation failure doesn't have to be the end of the road. It's just a complex, highly personalized biological puzzle waiting to be solved. Which leaves us with a pretty profound question to consider. Could the key to your successful pregnancy simply be a matter of perfect timing? Thank you so much for joining me on this explainer. Keep seeking answers and keep learning.